We can see the screen and we can hear you loud and clear.
All right, perfect. So thank you everybody for logging out, and sorry about the technical difficulties that I have, but I got asked to kind of talk about my experience utilizing the FiberLocker system to mechanically augment rotator cuff tears. And something I've really been fascinated about is attempting to get better results with our rotator cuff repairs. And I've kind of always been on the forefront of looking at what we can add. And this is something that I am very excited about. I think you all can be excited about. Ask me questions and we can learn together. Here are my disclosures. As Tom went over, I did my medical school down in Ponce, Puerto Rico, and then residency in St. Louis, and then went out to Philadelphia for my fellowship. And now I'm in Palm Beach Gardens, Florida, practicing private practice. I just do shoulder and elbow surgery. And so one question we all talk about is, why are we still talking about rotator cuff repairs in 2026? And this is some data from 23. And for tears that are large to massive, our failure rates are around 20 to 94%. In this data, about 20% of the tears failed. And if this were anything else, if this were a hip replacement, we would not be in business. This was an interesting study by the Seattle group and Dr. Madsen, and showed that despite all this research, and you can kind of see the exponential growth of research with the blue line, our recovery post-op scores and really repair rates have remained kind of intact. And so we are not winning. And so what can we do to be better? Well, I think we all identify some things why rotator cuff repairs fail. And certainly there are two groups: biologic reasons, age, smoking, diabetes, cholesterol, nutritional status, and genetics, and then some mechanical reasons. And, one thing I think we are learning in 2026 is we are seeing a lot more emerging data highlighting the importance of nutrition for rotator cuff healing. This was a study that looked at GNRI, and in patients with poor GNRI, they had a 5.6 times higher risk of re-tear. And this is kind of what we used to do. I did, like I said, I did my training in Philadelphia right off the steps by the Art Museum, and lots of us would just tell patients, "Hey, go take a few protein drinks," and really we hoped for the best. I think recently we've learned a lot more about this, and I give lots of credit to Dr. Riza Jazairi for educating us on the importance of targeted nutrition. And so now I think there are other aspects to this that we're really identifying proper nutrition and rotator cuff healing, as well as other orthopedic procedures. But we still have the mechanical reasons. We can look at this at the site of enthesis, where we may have weak bone, the biologic frailty, or at the tendon portion, where we have the thin tissue, the retracted tissue, and the delaminated tissue. And we all know that the majority of these rotator cuff repairs fail at the suture tendon interface. This is the MRI that I hate getting when we see that patient 3, 4, 5 months post-op, and you still have some of that tissue on the greater tuberosity that you had repaired, but they have this retracted type 2 re-tear. And so how can we improve? Well, like I talked about, we have identified some poor prognostic indicators: massive tears, fatty infiltration, severe atrophy, age, diabetes. And, up until a few years ago, we kind of looked at these and we would kind of say, this patient's not going to do well. And then I think Pat Denard really did a good job of highlighting the importance of this study by Quan and his colleagues to developing the rotator cuff healing index. And this really gave us an algorithm to identify how patients do after rotator cuff repair, and to really stratify which patients are going to do well. And in their study, Denard recommended that anybody with ROHI 7 or greater, they should augment. But when you looked at this, those patients with a ROHI of 5 or 6 still only had a 68% healing rate. And so about 32% of those patients were failing. And so I never even really took this. And so for me, anybody with a ROHI 5 or greater, I'm really trying to augment at this point. And so we all know that structural augmentation decreases the risk of re-tear. This is a recent systematic review and meta-analysis looking at this, and what they found is there was a 35% reduction in re-tear rates with augments. Allografts were the most effective, but admittedly, we really have not seen the difference in patient-reported outcomes.
Dr. Hill, may I interrupt quickly? If everyone can put their machines on mute, unless you've got a question, it would help with the background noise. Thank you.
Thank you, Tom. And so when we look at augments, we look at different ways that we can augment. Is it mechanics, structure, or biology? And here are some of the different augments in the market, and I've actually tried all of these. I've tried the collagen scaffolds, the nanofiber augments, supplementing the enthesis, the biologic SCR with the long head of the biceps tendon, dermis, and it's great to have multiple tools in the belt. All of us orthopedic surgeons like all these other all these gadgets, but it was also very overwhelming at times trying to figure out what was the best thing to use. And so like lots of us, I was scouring the internet, and I came across some videos from the San Diego Shoulder Institute course from 2024 about the best rotator cuff techniques and tips. And what I saw was Grant Garagos from Rush won this, and he won it discussing a technology that wasn't even available yet in the United States. And I thought, holy cow, this is really interesting. This makes sense to me, but I couldn't get my hands on it. And so then early in 2025, I saw this headline come across that ZuriMed had gotten FDA clearance of its FiberLocker system and was going to be cleared in February of 2025. And so again, I kind of really didn't know what this was. I said, okay, so I saw this short clip from Garagos showing this, but what is the FiberLocker system? And many of you may not know, but Isaac Merrick Singer was he was an inventor, actor, left the home at age 12. And what he was famous for was the Singer sewing machine. This was actually a sewing machine that people could take home and utilize. And what ZuriMed did is they identified the strength of the sewing machine and identified that they could utilize this to place an augment on the rotator cuff much better than we have currently. What's wild, and really not until I looked up Isaac Singer, is that here in Palm Beach Gardens, we have an island named after his eldest son, Singer Island, that's just a few miles from where I live. And so Isaac Singer was very profitable, and obviously his kids then came down to Palm Beach and were wealthy as well. But so what the heck is this FiberLocker system? Well, what it is it mechanically reinforces the rotator cuff, utilizing a patch tendon attachment, and really improves that structural integrity at time 0. And so what you get when you get this is you get two things. You get the FiberLocker instrument, which is this hand piece that goes on a shaver, and then you get this SpeedPatch. And what is a SpeedPatch? Well, it's a permanent graft that's made of non-woven polyester. It looks like a felt material. It's very porous and it's flexible, but also it has very high retention suture strength. And so this is what it looks like. There's a reciprocating tool, or the FiberLocker, interweaves the patch and multiple passes through the tendon. And here's a gelatin showing how this looks. And many of you who have seen Tom Borg at a meeting, he's probably had you look at this, and where you can see actually all these fibers going through the rotator cuff. And this frequency of the microblade, it's 200 or 2,500 RPMs, that ends up giving you about or over 20,000 fixation points if you leave it on for 90 seconds. The needle is only about 6.5 millimeters. And so, like many people on the call, I said, okay, well, where's the data? This seems cool, but do we have any actual studies that support this? And what ZuriMed first did is they looked at this, and they, like most studies, they did an ovine model where they augmented rotator cuffs, and they compared it to non-augmented Mason Allen sutures. And what they found was that the fiber locker systems increased the force required to cause failure for the repairs. And it was about almost a 2 times increase in repair strength. They then took this a step further, and they compared this and another ovine model, and they compared it in 3 different methods. One was a regular transosseous equivalent, where they used Arthrex anchors medially past several sutures through the rotator cuff tendon, tied the sutures, and then brought them over to Stryker anchors laterally. They then, in the second group, they utilized the pitch patch. And how the pitch patch worked is, you can see it in the picture. You lay it on top of the rotator cuff repair after you've already done your conventional transosseous equivalent. And then they used number 2 fiber wire to suture that patch along the medial side. And then they put 2 extra anchors laterally and anchored that down laterally. And then they did the speed patch with the fiber locker. And again, the similar transosseous equivalent at first. You utilize the fiber locker to suture that into the rotator cuff, and then 2 separate anchors laterally. And what this showed is that based on this data, there was a 2.65 increase in time zero fixation with that fiber locker system compared to the transosseous equivalent and the patch augmented rotator cuff repair. And then lastly, this is a common question, is, okay, so you can put this patch on, but lots of us have seen the patches where either patients have reactions or they really don't integrate. And so this was the second part of that first study, where they looked at the sheep, and then they looked at them at 6 weeks and 13 weeks. And what they found is, number one, most important probably, is there were no adverse tissue reactions. Second, there was implant integration after both 6 weeks and 13 weeks. And they actually showed ingrowth after the 13 weeks. And so all of these things looked great to me when I kind of was doing my research on this. But as all of us do, we take some of that basic science research and we say, okay, well, how about if you just put this speed patch on a rotator cuff in the lab, and then you pull on it. I want to see how good this thing is. And so this is a cadaveric model kind of showing, and Tom's there in the background. You can kind of just see that his beard, but you can see this really has good fixation. And so this was enough to convince me, okay, well, let me see how this does in a patient. And so this is an example of a 75-year-old with acute on chronic rotator cuff tear. And, just looking at the MRI, you can already kind of see that this tissue quality isn't going to be great. And these are a lot of the patients that they end up, they say, hey, I want something arthroscopic. And when you get in arthroscopically, you look at that tissue and you think, gosh, how was I convinced that I'm going to try to repair this? I'm trying to pull this over, and really that tissue just falls apart. And these are the patients that historically I would kind of do a single row repair if I could. I didn't want to over tension it. And I think patients would get better, but I wasn't always sure if they healed. And so here's what I did. Is this was a double row repair. And then this is how you apply the speed patch in the fiber locker system. So we've switched to my meta glasses. I apologize if any of you get seasick by watching this. I put this through the plastic cannula here laterally. I kind of fold it up like a taco. And I just use what I call a cuff grasper to put it in. And then I switch to the crab claw to kind of lay this down. And it wants to lay down. It wants to kind of lay on top of that rotator cuff tendon. And so I just press it down again over my regular rotator cuff repair. And then you come in with the fiber locker and you're sewing this into the rotator cuff tendon. And I start medially and leave a little bit laterally to make sure. Then I utilize the stay sutures that are in my lateral anchors to then pass sutures through this. And you can kind of see here where you see that needle coming through. This can't hurt the bone or anything like that. The needle's not strong enough. And then this will allow you to pass those sutures through lateral. And this is what you get. So this is that same lady where, I was freaking out. And now you have almost this normal looking cuff tissue that's really in a load sharing environment. Here's another case of a gentleman that had a revision rotator cuff repair. And so he was 62-year-old, had a prior C. acnes infection. The image on the far left is the debridement after the infection. And then we got an MRI. And again, I think lots of people probably on this call would say, hey, that for me, that's just a reverse shoulder arthroplasty or something of a salvage. But this gentleman was very, very active, wanted to get back to surfing. And so here is the MRI demonstrating a pretty large size tear. And so for him, I did do the single row. I did not want to overtension him. And then this is us putting the SpeedPatch on top. And now he's 5 months out. He rated his ASES at 91, VAS of 1. He just came in for his 5-month post-op and went and caught some swells down in Puerto Rico and is ecstatic with how well his shoulder is doing after he saw me. And he was really devastated after his infection and thought his surfing career was going to be over. Other questions I get are, hey, okay, well, this adds the mechanics, but is there anything else you can do to really supplement this as well? And so here is a patient that had a rotator cuff tear, but she was adamant that she also wanted BMAC. And so this is what this looks like: is we aspirated the BMAC from the proximal humerus, and then this is injecting it back in, and you can really see how the SpeedPatch works as a sponge to keep a lot of that material. And so I think that's a fascinating technique that also you can do. Other questions I get are, okay, well, what happens at a later date? I saw the ovine studies at 6 to 13 weeks. And so this is a 48-year-old that I did an arthroscopic biceps tenodesis. And unfortunately, around 6 weeks, he's trying to fling a backpack over his shoulder and he popped his long head of the biceps, his tenodesis. But we had also done a SpeedPatch. And so this is what the SpeedPatch looked like at the 6-week mark. And really had integrated into that rotator cuff, and it almost looked like normal tissue in there. We ended up doing an open biceps tenodesis for him, and he's only about 4 months out, and the VAS or ASES of 96. And so a few tips or tricks for this, and one thing is, all of us have been in the shoulder where we have really small subacromial space. And so all augments are tough on that. I think in those patients ahead of time, I'm possibly doing a acromioplasty so I have a little bit better angle. Because one thing you want to do for this is to really suture that SpeedPatch in. You need that fiber locker system to have around a 90-degree to 60-degree angle. And so if you can't get that, it becomes really tough. And after about the first couple of times, you can kind of see where you're getting at. And most of the time, I'm just utilizing the portals where I put my medial row anchors to bring in that fiber locker. The other thing that can happen is if you're not careful, sometimes you'll push this very much too far medially, and you'll start fixing it on the rotator cuff. And so identifying where you want it to sit prior to utilizing the FiberLocker system helps as well. And then in that first case, you saw me using the hard plastic cannula. Well, here's more kind of a typical passport type cannula. And you can see once that comes in, it really just pops open. And so I think that is a little bit easier as well. Kind of hold it down, and then you come in with your FiberLocker suture to get this to sit down. And that's also helped quite a bit. And so I blazed through that, but rotator cuff failure is pretty predictable. We know who's going to fail, and most failures are mechanical. If we change the mechanics, we may change the outcome. And that's why I believe the FiberLocker system, a couple of things that are big for me. It's easy to deploy. It's not affected by your typical rotator cuff fixation technique. If you're a speed bridge, if you're a single row, what's nice is you get to lay this on top of that. It is synthetic. And so we don't get the soft tissue reactions. One other thing for me that's beneficial, being that it's synthetic, is down here in Florida, a lot of my insurance companies, they pay for implants. And so where biologics, we have a tough time with certain insurance companies, this is reimbursable by several insurances. And then the fixation is unbeatable. And so, augmentation isn't magic, but certainly we're hoping to shift the odds. And I'd like to take that opportunity to see if anybody has any questions.
Yeah, we can just fire off if you've got a question. We don't have a monitor, so just speak up as needed.
Tom, a couple of things is you've been kind of across the United States showing this to other surgeons. What things are you seeing when you get this in somebody's hands that they're most surprised about?
So it depends. If it's a first time clinical evaluation, ease of use, the fact that the patch is relatively simple to introduce, and the fixation, even clinically or intraoperatively, you do get a sense of how this integrates into tissue. In a cadaveric setting, as you demonstrated earlier, having direct access to the patch and really stressing it and pulling it, it's remarkable. It's uncanny how strong it is. But intraoperatively, just the ability to position the needle, as you said, at a 90-degree angle, run it over the patch for 90 seconds and get full integration. One thing that actually came up in a conversation today, for those massive and complex tears, if there's a delamination, for example, and there's a longitudinal component, if you do a margin convergence and then you anchor the tendon, if you're able to put that patch over the entire complex tear configuration and integrate it, it tends to bring everything together, including the two different lamina. So you can fix a delamination, you can integrate that patch into the longitudinal component, and you kind of recreate the mechanical stability of the entire cuff by virtue of the surface area of the implant. So to answer in one word, Dr. Just ease of use. It's really simple to use and it's really strong, and you know it at time zero.
Yeah, that's exactly right. That patient that we were actually doing the BMAC, I mean, she had kind of a delaminated tear, and in those patients, so it's 2 by 3 centimeters, and sometimes I'll utilize it longitudinally. Other times I turn it horizontally. And I agree with you. It sort of recreates that rotator cable and lays across and does a great job. One question that came up from Kevin is, what outcomes have surprised you? Structural healing, pain, or return to function? So Kevin, good question. So I was very skeptical at first that this would decrease patients' pain relief, and I'm very conservative with my rehab protocol for rotator cuff. Prior to utilizing the FiberLocker and SpeedPatch, most patients were in a sling for 6 weeks and really no strengthening the first 3 months. And I did not want to change that right away when I was switching over to this, because I wanted to keep my kind of protocol consistent. And like most of us, when you're trying something new, I identified the worst cases. And so that guy with the C. acnes was one of the first where I thought there's no chance this is going to heal. And then all of a sudden, when they come in to your 4-week, 6-week appointment and they have full range of motion, they don't kind of have that hiking shoulder. I was blown away. The other thing that I think it has helped with is because it's dispersing those forces more, I do believe that patients are having less postoperative pain. And we're actually looking at that, trying to identify. We take pain scores at 2 weeks and 6 weeks, and we're trying to identify, is that something that I'm just, anecdotal, I'm believing, or is there actually data to that? And so really all of those I've been very impressed with. I started getting some MRIs on some of the patients early on, but I was getting them at 3 months, and so there was healing there, but it was still a little bit too much inflammation at that, or I guess signal at that point. And so I think some more studies are going to come out with MRIs at 6 months or even a year. That's going to give us some better data on the healing rates as well. Andrew, talks about the stress shielding effect with the SpeedPatch. And so one thing I think if you're utilizing SpeedPatch, I think it's more of a share loading concept where it is integrating into the rotator cuff. And really the best way to anchor it down is, I think, if you're using those lateral row anchors to offload some of your repair, as you could see in that kind of second look, where you're really getting that integration into the rotator cuff. I have not been concerned about the stress shielding effect. I haven't seen it. Tom, have you seen it in anybody that's utilizing this thus far?
No. In fact, one of the design benefits of this construct is it went through a biomimetic design process. So there is a elasticity coefficient or modulus in this patch. It stretches and it moves, not exactly like, but very similar to the native supraspinatus. So it's designed to not stress shield. It's designed to actually load share, but protect the structural integrity of the repair at the same time. So the idea is that we want to affect more robust healing by allowing the biology to do its thing in a secure, mechanically enhanced environment.
Yeah, and another good question. So Jacob Triplet, thanks for joining us tonight, and you didn't miss it. So his question was, have I utilized this in partial rotator cuff tears? And the answer is yes. I was cautious at first, so I had used a collagen implant for a while for my partial repairs, but in some of those patients, unfortunately, I thought that we were getting a reaction in a not small number. I was actually having to inject them at around the 3 to 4 months mark with some steroids just to calm down that reaction. And so this made sense to me that, hey, we could take these partial tears, add this on top. One of the easy things is it's easy to add it on top, right? You're not putting any anchors through the rotator cuff. You're not putting in staples. And then I have, in those circumstances, put 2 knotless anchors, all suture anchors laterally, and kind of utilize that to hold it down. I don't think you necessarily have to. And we're also going back and looking at that compared to other methods that we utilized in the past. And so I think those patients have done very well. I think this implant bodes itself well to that as well. And so I think more data is going to come out, more studies are going to come out to show kind of real how that heals. When you start utilizing this, this talk was just on arthroscopic rotator cuff repairs, but you kind of see all the different concepts for those of us that are in shoulder and elbow surgery or sports, where you can add this to different techniques as well because of the fixation method. And that question just came up. Have I utilized this in different spots? And I haven't, but I've been chomping at the bits too.
So, Dr. Hill, what about augmenting a subscap peel or a diseased subscap, injured subscap during an arthroplasty?
Yeah, and so I actually was just talking about that with my rep today. Is would this bow to a anatomic total shoulder arthroplasty? And I so one thing how I do mine is I do LTOs, and so I haven't really utilized it for that fact, Tom. But I think if you're a peel person or you're a tenotomy person, I think this works really well and just reinforces that. The other spot I think you could use this is, like tricep tendon tears. This would work great for the foot and ankle surgeons. I'm sure that there will be uses for Achilles tendon tears as well, and also for like quad tendons. All the other sports guys out there that will kind of find other ways to utilize this.
Yeah, so just for compliance reasons, I have to point out that we only have a rotator cuff indication at the moment, but certainly looking at expanding into other indications, many of which you just identified. So,
And so Dale has a good question. Are there cases where you specifically would not want to use the speed patch? For me, really the only cases that I have bailed where I thought this could potentially be useful was either in those shoulders where really your subacromial space is just too tough to get into. You realize that you can't get an augment in there, and possibly you've been in there a while, and that space is just shrinking on you. And so there's been a couple of cases where I did, even with an aggressive acromioplasty, I didn't think that I was going to, one, get the augment in, but then two, be able to get that fiber locker at the correct angle. And so I'll even check that sometimes. And we all come across those shoulders every once in a while. And so that's really the only time that I've identified, hey, I don't think this is going to be beneficial. I should say the one other spot that I haven't tried it, um, and I'm looking forward to it, is a subscap, an isolated subscap. I do those arthroscopically, and I think it would lend itself well. I just haven't tried it on that yet.
Dr. Hill, getting back to your angle of attack, you're a beach chair operator when you fix cuffs, correct? So in those cases of a low ceiling or probably more appropriate of a medialized tendon, a retracted tendon, have you tried an advisor portal to get more perpendicular as you speed patch?
Yeah, and I've done that once or twice where I had to use Navisor's portal to kind of come in and get that medial portion of the speed patch. And you're exactly right, Tom. Um, and then you can still fix it laterally. And so, if it's really a case that you think it would be beneficial there, I think that's another good spot. I mean, really, any spot you can get a spinal needle in, you can put that fiber locker in. And you're always just kind of looking for what is the best angle of attack. And so, where I typically introduce the speed patch is right where my lateral cannula is. And I showed just like in that video. And then I come in normally for the fiber locker where I put in the medial row anchors. Um,
For the
Go ahead.
benefit of those who don't know, we are designing a slightly curved distal tip on the fiber locker. So instead of a completely straight approach, you're going to have, we haven't determined the exact angle yet, but likely around 21 degrees to make a more perpendicular approach easier in those tight cases. And so that hopefully we'll have that early next year.
And Chance has a good question. And so, what technique do you use to fix the speed patch laterally after you've placed your lateral row anchors? So the Chance that the lateral row anchors I currently use have a stay suture in them. So most of the time, if I'm planning on augmenting, I leave that stay suture there, and then I'll come back. I'll introduce the speed patch, fix it, and then I actually use the suture passer, like I showed in that video, where I'll take those sutures and pass it right through the speed patch. The one thing, the company I use, that I wish that was a knotless mechanism, so I have to tie over the top of that. every once in a while, if I accidentally cut those stay sutures or I utilize those to bring down a dog ear, I will put in another knotless all suture anchor, and I think that's a great way to bring it down as well. And what is nice is that the SpeedPatch will allow you to pass suture through it, and then it does not pull out. And so even with just a small little portion of the corner of that implant, it will not tear through. And so I think that's really helpful. David Johnson is asking, will there be a way to utilize the felting needle to fix the patch to one laterally? Tom, you think that's so it does not. So David, the one thing is that needle will not go through bone, and so if you're trying to fix it in the bone, and you're pushing too hard. So if you're really pushing down and you're over the greater tuberosity, you'll see that needle will it won't break, but it will stop functioning, and so currently there's no way to kind of felt that into the greater tuberosity laterally. And Anthony asked, how can you tell that you've attached the patch completely? Can you tell visually or probe it? So Anthony, great question. So what is recommended is 90 seconds to go over that and fix it into the rotator cuff. But I don't trust that completely all the time. And so I go a little bit more. And what I really do is I go over those edges at every corner, because the last thing I want is to not have that patch completely fixed and either to impinge or create a little lip where then I think that the patient could, and I don't actually think this would happen, but then could pull it off. And so I will then kind of come around and utilize the fiber locker without the needle driving through and see, hey, is that fixed well? One thing you can see though is once you kind of start going over it with the fiber locker, you'll be able to see that patch, and it really looks integrated into the cuff tissue. And so lots of times you don't even have to really probe it or push on it, because you can see kind of it's dimpled into that rotator cuff. Michael has an interesting question, and I know a few people that do this. Is if a surgeon doesn't want to take the time to attach the SpeedPatch to the lateral anchors, how much benefit do you think they are losing by not doing this? And so, Michael, one thing I believe the SpeedPatch, when it works the best, is when it's in that load sharing mechanism. And so that's why I want those lateral anchors, because I want it kind of taking a little bit of the load off my medial row anchors and my rotator cuff repair. I do know some people though that they'll do their standard repair, and then they'll turn the SpeedPatch sideways and lay it on top. And what they tell me is they're recreating the rotator cuff cable, and even with just that, they've seen good outcomes. I have not done that too often, but I think it's interesting concept that they're looking at. Tom, have you seen quite a few people that don't choose to fix it laterally?
No, there are some, but the point to make around this is that if you think about it, if you put the patch on top of a torn cuff and then you integrate, particularly on the lateral side, anchored suture through the patch tendon construct, biomechanically you transfer the failure away from suture tendon to suture patch. So the patch takes on mechanically the burden of the suture load, protecting the underlying tissue. So there is a mechanical difference when you do anchor through the patch, and it's our indication it is approved to be used in conjunction with anchors. So in other words, an anchored repair. But if you can get that anchored suture through the patch, actually either medial or laterally, it does enhance the mechanical integrity of the repair.
Yeah.
And it does so, I think our stats are between 10 and 15%. So Michael, to your question, even if you don't anchor through it, we're still talking about mechanical enhancements in the 600 plus Newton range.
Yeah, and Kevin has an interesting question that I was always concerned about at first too. Is Kevin, have you seen complications or compromise of your repair from the sutures utilizing the fiber locker? And so, Kevin, what's neat is that needling device. It will pass some of the sutures, even if you come through your suture. It will utilize the speed patch, and it almost weaves into the sutures as well. And so it will not cut through them or anything like that. If you go over an area too much, you will start to see the speed patch thin out some, and sometimes you can even see your sutures um, kind of almost through it. But that's the only thing that I've seen it, and I have not seen where it actually cuts the sutures, and I don't believe it can. Is that correct, Tom?
No, that's correct. And we're producing a white paper to show that it actually, to your point, will drive fibers from the speed patch into the underlying braid. And we're hoping to show that this actually enhances the overall mechanical integrity, because now you're connecting the implant to the suture, and you're just creating a greater stress dispersion across the entire repair. And if you internally externally rotate, if you put this patch on top of an underlying repair, you'll see the entire construct move as one. So there may actually be a mechanical advantage to it, but we have to prove that.
Yeah, it's neat. And Tom, I've seen other people utilize the patch other ways, right? I mean, they're not just always laying it on. I think some people um, kind of introduce it and tie the sutures immediately, and then also utilize the fiber locker over the top. How I use it is I kind of like to attack my rotator cuff repair just like I normally would, and that's what I think the good benefit is you don't have to be thinking about, hey, do I need to pass passing sutures prior? With some of the other implants that I used, you had to almost, before you did your repair, identify, am I going to augment this with something structural? And if I do I pass some passing sutures medial to my medial row so I can shuttle something in? Um,
Yeah,
the nice part about the speed patch is you don't have to worry about that. You can kind of see how your repair is, and then identify, okay, will this benefit, and just put it on top. Um, Chelsea has a question for you, Tom. Could you cut the speed patch, or does that affect the integrity of the patch? So if you cut it in half, or cut it to shape the tendon.
Yeah. So in its current configuration, there is a strength reduction if you cut the patch. It's nominal, there is a strength reduction. It also tends to fray at the cut edge. We are in the process of designing, through a special, felting needling process, a patch that will be cuttable or customizable, and not have a reduction in its overall strength. I mean, obviously the size of the patch, if you cut it in half, then theoretically you only have access to 50% of the material. And your point earlier, Dr. Hill, which I should be highlighted, the 90 seconds, the 90-second rule, if you will, is based on the number of fibers in the implant. That's sort of the point of diminishing returns as you fiber lock. If you go for 10 or 15 minutes, you're actually driving all of the fibers into the tendon, and you're missing that scaffold benefit. And so at this point, I would advise against cutting the patch, but stay tuned. We hope to have an option here pretty soon.
Yeah, awesome. I mean, if you guys ever catch Tom at one of the meetings, make sure you get over and kind of check this thing out, because I think um, the first time, like I said, I found out this was available. I was actually visiting a buddy in Dallas, and he said he had used it, and so he gave me Tom's number. I called him, said, Tom, I want to use this for a rotator cuff next week, and he probably doesn't like me sharing this, but all of a sudden he finds himself in Jupiter, Florida, and he's giving an in-service to some nurses at our hospital. And what was funny is the reason I had wanted to utilize it the next week is because I was operating on a nurse, and I thought this would be very beneficial because she wanted to get back to work fast. And so Tom did his in-service, and I saw the nurse for her pre-op appointment that Friday, and she actually had taken one of those little gelatin things, and she was so excited. She said, Dr. Hill, you're going to be utilizing this on me, right? Like this is the whole reason you had them come show this. And so that was really neat. Brad had a great question. Brad, I have not done this. So could you soak it in BMAC before implanting? Um, the patch is very spongy, so I certainly think you could. Um, you know, like I showed in that image where that was me injecting the BMAC directly into the patch, and so that's how I preferred to do it, just because I think during the felting process you may dilute or get rid of some of that BMAC as you're trying to implement it into the rotator cuff tendon. But I don't think you're definitely burning it in bridges if you did that. And then Greg from down south, any experience in utilizing the augmentation partial thickness pairs as only rather than taking down and repair? And what's the technique? So Greg, yeah. So I have done this in partial thickness tears, and I have been very, very optimistic at how the patients are doing. You know, like I talked about earlier, is previously I utilized a collagen implant for a lot of partial thickness repairs, and I never really was a great believer on taking down the completing the repair and then doing a full repair. And so with this, after about 3 months of utilizing it, we started doing it on partial thickness tears as well. And I think it bodes well. Sometimes when it's more articular sided, I'll do like a pasta repair and then I'll lay the speed patch on top. But if it's a bursal sided tear, I've laid this on an unlay technique, and then I will offload it and put 2 knotless anchors laterally and still secure it laterally, and have had good results.
How's our nurse doing, Dr. Hill?
She is doing fantastic. She's back to work, and she got promoted, and she the shoulder has not slowed her down at all, and so she is very ecstatic that we're able to use this, and has been good.
We should endorse a study proving that the use of this implant is good for your professional career. If it's a
Right,
step up the ladder.
right. And one thing, you know, this is as this gets more utilized, uh, this is also a big thing, is patients are seeking people out. And I've had a few patients come from over this across the state because they identified that we utilize the fiber locker system. I didn't touch on this, but um, you know, when I first started utilizing it, again, I was 6 weeks in a sling. More recently, and this is after talking with other physicians who are utilizing the speed patch, we're 2 weeks max in the sling for anybody. And there's even some physicians that are a little bit more aggressive than that. But I think that is one other component that that patients like, is we get them out of the sling. I still don't do strengthening for 10 to 12 weeks.
I'm almost
But
done it, so I'll be at the channel later.
Brian, Nathaniel, I think you're off mute there. But so, you know, one other thing that you guys can do is certainly expedite your recovery and getting out of the sling. And Tom, have you seen other surgeons? I know a few that I've talked to are really pushing that, just because they can't see patients that, you know, they're moving too well, and they say, why would I still keep the patient in the sling for six weeks?
No, this was one of the unexpected early comments that we started to get, you know, albeit anecdotal, but very consistent, that patients felt better. Their pain seemed to be lower, and they were able to move much earlier. And so we do have a number of physicians who have changed their rehab protocol, allowing patients to move. I mean, we have, you know, obviously we've got one physician who you referenced, who has been very optimistic in his patient population, and he's basically giving patients the option as to whether or not to wear a sling. Now, you know, he does require slings in certain patients, but in those patients where he thinks there'd be a benefit to it, and he's you know, he's we hopefully will publish the results, but across the board, in the population of physicians we've heard who've done, 10 or 20 shoulders, they are, they've either shortened their sling requirements or are thinking about shortening their sling requirements.
Yeah. It took me about 40 cases until I finally started doing it. And mostly it was because my PA was seeing those patients post-operatively, and he came to me and said, Dr. Hill, I can't keep, these patients are doing too good to keep them in the sling. Can we get a little bit more aggressive with this? Dr. Gillot had another question would you consider utilizing this for tuberoplasty effect? Greg, I have never done a biologic tuberoplasty. I'm sure some of my SCRs have failed and become tuberoplasties.
Same. I've not seen it used for that, but
a couple of things I don't think it would work as well as, one of the big advantages is you are utilizing that fiber locker to suture this into the rotator cuff tendon.
Right.
And so it does not have the same effect. You can't do that into the bone. And so if you're a believer in tuberoplasty, I think probably sticking with the dermis is the better bet there. But I don't have any experience.
Yeah, but again, we only have a rotator cuff repair indication approved. Now, that said, I was at the first international SCR meeting a few weeks ago with Dr. Mihata et al., and there was a conversation about this implant, and due to the not just the biocompatibility, but the fact that cells like it, could this patch or a construct like this patch serve as a way to to bridge the humeral glenoid space for an SCR type repair and somehow inspire cells to grow into the patch. So interesting conversations, but outside of our current focus.
Yeah. And one other thing, if I didn't point this out enough, is those of you that involved in surgery centers, the nice part is this is an implant, and so in those insurance plans that cover implants, I utilize this all the time at my surgery center, which with other augmentation techniques has been cost prohibitive, and so I think that's another reason that you consider the utilization, because you can use it at the surgery center as well.
So just to kind of wrap up here towards the end, and for the benefit of everyone on the call as well. So we launched back in February 2025, as Dr. Hill pointed out earlier, and we just celebrated case number 2000. And so the results so far have been excellent. We have not had any instances reported to us of any rejection or infections, and so we've been quite satisfied with the performance, not just intraoperatively, but as we're discussing now, the post-op feedback we're getting has been spectacular, and to be perfectly honest, somewhat unexpected. And so we are in the process of designing ways where we might be able to correlate this technique with some of the post-op benefits, and we'll keep everybody posted if we're able to get some peer-reviewed evidence that there is a benefit to this mechanical approach with this particular implant. And so that said, if there aren't any more questions, I'll give a couple more seconds to anyone who wants to chime in.
Tom, thank you very much for allowing me this. And if anybody has questions offline too, feel free to reach out. Happy to kind of talk to you about the techniques and what we've gone through. And so don't hesitate.
Thank you, Dr. Hill, and thanks everyone else on the call for making the time tonight. We really appreciate it, and thank you for your support.
All right. Happy Thursday. Thank you. Tom, see you next week.
Look forward to it. Thanks, Dr. Hill.